period of time today to do this in. So I'm going to make my comments really brief. Each presentation is going to be about 12 minutes long. We're going to try to keep to that time so we finish on time. And I'm going to ask that people reserve questions until the end of all 4 presentations. There's probably going to be another group coming in here, and so that you can meet with the presenters in the hallway. Okay? So, Dr. Sharma, I'm going to give you first, and I'll leave it to you.
Okay. Thank you for the honor that we have given a chance to present our data. My name is Sharma from Uppsala University, and I am presenting on behalf of my colleague, Professor Mureșanu from the University of Cluj-Napoca in Romania. And as you can see that this is multi-organizational research work, US Department of Defense, Swedish Strategic Research, Government of Sweden, and European Office of Aerospace Research Laboratory, and also US Air Force and all other organizations. So we are working basically to understand different kinds of brain injury and try to develop a therapeutic approach using nanotechnology, because this was introduced to us by US Air Force Research Laboratory, and we are working since 2004. And we have nothing to disclose. There is no unnamed drug, and it has no conflict of interest so far. And I have to say that what I am telling is my personal opinion. It has nothing to do with any other organizations or US government that we are working for. So this is Dr. Mureșanu from Romania. This is my wife, Aruna here, and this is Rudy. And we have a long project on different kinds of nanomedicines approach and different drugs. So recently we have started working on blast injury in the brain, and this is most difficult to model in the laboratory. As you know that our military personnel are often exposed to such kind of injury, and there is no treatment at all. So what we would like to do that we have created a well-known model of blast in the laboratory, and we exposed rats, of course, the anesthetized one. In real cases, people are not anesthetized. So these are the basic difference in the experimental model and real situations. And then we try to treat them with actinium nanowire delivery of cerebrolysin, because cerebrolysin is a drug that is not one, it has several neurotrophic factors in combination and peptide fragments. So this is multimodal drug. And this TiO2 nanowire is a patent from University of Arkansas Fayetteville. My colleague Dr. Ryan Tian and Dr. Asia, they are doing the labeling. So as you can see that blast is very uncontrollable injury to the brain. It can have many different facets and very quick. The other aspect is missile injury, and you can see it depends on where it is penetrating. It depends that produces the real brain damage. So actually this is very difficult to produce this blast model in laboratory, but we are doing something to understand. And as you can see that whenever there is a blast injury, you know that many axons and neurons, they were cut, and therefore there is a devastating change in the brain. Blast injury is very rapid, and you can see that from 0 to 0.3 seconds. These are the waves propagating and injuring the brain. And as you can see that it can be mild, moderate, severe, even penetrating, or unclassified. And for example, you can see that how many patients can be seen with blast injury in every calendar year. And this is the center of the blast, and the waves propagating like this and producing brain injury, and that is very common. This is one example how blast injury can affect our soldiers. We are using the Swedish model of pipe blast model, where a gas is injected into this with a different below basal pressures, and the rats anesthetized are placed here, and there is a membrane in between. So when the gas is pushed with certain known pressure, then the membrane ruptures and it creates some kind of blast experience. So basically the method is that anesthetized rats were placed and their torso was wrapped, and so that only the head is exposed. Of course, they are anesthetized, and two different pressure they used, 150 and 250, and the time 8 hours and 24 hours. Brain edema, blood-brain barrier, and cell and tissue really where it's. To just make it short, there are two things. The brain injury, as we have seen in our animal model, depends on the pressure and the time. So you can see here that low pressure damage has less changes. This is the blood-brain barrier leakage to advanced iodine, and water content is edema. Cerebral blood flow is reduced, and neuronal damage you can see that they are increased for pressure-related things, and these are the viruses and also 9 residues. And these are different time periods. It depends. When we have given this nanowire cercolysin in low doses, we have some neuroprotection, but repeated administration of cercolysin is really doing good protection in our hand at the moment. And these are the normals. So what we can see that radioiodine leakage has increased with pressure changes, and also the edema formation is also elevated, and this staining showed many neurons were damaged. So these are the basic parameters. Then we have used this nanowires. This is US patent at University of Arkansas, and this is cercolysin. This is a liquid, and it is bound on these nanoscaffolds. So I can show you these glasses here, and this is the 24-hour blast injury, and this is normal cercolysin is given. You can see still there are changes. But when we have given this nanowire cercolysin, this picture looks a little better than this one. Then these are the hematoxylin and eosin staining. You can see that this is untreated blast injury, very neuronal edema, and spontaneous of the nerve is clearly visible. And here is the normal cercolysin, some protection, but nanowire cercolysin is protecting much more than the cercolysin drug alone. We tested our hypothesis based on electron microscopy, because I am basically a neuropathologist, so I believe which I can see. So you can see here, these are untreated blast injury, circulation, edema, and cell damage. And this is cercolysin alone in blast injury 24 hours. This is 8 hours, 24 hours, very progressive damage. And also here we have used nanowire cercolysin, and we can still protect the neuroplate, not 100%, but probably 75%. So the main findings is that cercolysin 2.5 or 5 milliliter per kilogram given intravenously 2 and 4 hours after brain blast injury significantly reduced brain pathology for 8 hours. And larger doses, repeated combination is also good after 12 or 24. We believe that nano delivery of cercolysin is better, as many people have claimed that any kind of nano delivery, we are doing nanowire, but they can be delivered in other ways as well. So we can say that we are able to reduce some of the blast injury induced damage by nanowire cercolysin, but of course the model is far from perfect, but this is the beginning, and we are trying different kind of models to understand or simulate the clinical condition that is not so easy, and also try to different kinds of drugs that whether this nanowire alone is not doing anything, so it means the drug should be powerful enough to have neuroprotection. And these lines we are working, and maybe we can show some more results in next year. And these are our supporters. It's a large project running. We have different kinds of support from all over the world, especially in the United States. These are our collaborators. I am from Uppsala University, and I look forward to your kind suggestions for further improvement. Thank you very much.
We have some time for questions. Are there any questions? We have a few minutes left.
Yes,
I
please.
have a question, maybe it's naive, but what is the benefit of this nanotechnology? I mean, that this method works better because it's, I understand, because it's...
There are two things. This is a very good question, actually. It's not naive. Many people, even we, are asking. Actually, so far, the knowledge is available. If you deliver good drugs using nanotechnology, we are using nanowire scaffold, but some people are using soft nanoparticles or biodegradable nanoparticles. Then they penetrate much better into the nervous system. In our case, in nanowire, they make connections in the nervous system very fast and wide areas, and they release drugs slowly, you know. So it is like inside microinfusion pump. And the second point, that they are bound with nanowires or nanomaterials, so they are degraded. They take long time to degrade. So in all, making short, the drug has more availability, the bioavailability is higher, and degraded less, and penetrates faster, wider areas of the central nervous system. So that could be one of the reasons that it produces better result. But we cannot make a bad drug to good if the drug is not working by just giving nanotechnology. So far, this is the idea that people are working. And on the other hand, these nanoparticles also do damage to the central nervous system. But it depends on the type of the nanoparticles, or their size, or even zeta potential, or their electrical charges around it. So these factors are very important, and we are working on this. So that is the reason so far we have concentrated on titanium nanowire drug delivery, because titanium is most innocuous so far in our and also according to literature.
Thank you very much.
Thank you, sir.